Our next speaker, Heather Forkey, is the Chief of the Child Protection Program and Clinical Director for the Foster Children Evaluation Program at the University of Massachusetts Children's Medical Center, and she's Associate Professor at the UMass School of Medicine. In addition to her clinical work with children exposed to abuse and neglect, foster care, and trauma, Dr. Forkey has been the recipient of local and federal grants to address issues of children in foster care and to translate promising practices to address physical and mental health care needs of children who've been traumatized. Dr. Forkey has published on the care of children in foster care, and she's going to speak today on common behavioral presentations of trauma in pediatric practice. So, welcome, Heather Forkey.
Good morning, everyone. I'm so honored to be here. And I have nothing to disclose either. No, that's wrong. I have to disclose three things. One is, I'm originally from Long Island, and when I get all worked up, I start talking like I'm back in Long Island. So, as we're going, I might go there. The other things are that I have 5 kids, and that winter is long in Worcester, Massachusetts. That will become important later. What are we going to talk about? We're going to talk about what trauma looks like in children, how we can recognize it in pediatric practice, and how to respond when trauma is identified. So what does trauma look like in children, and why do we have to look at it again? Part of it is because when most of us trained, trauma equaled post-traumatic stress disorder. So we were trained that trauma equals what we see in young adult males who return from wartime trauma, because that's how the definitions of post-traumatic stress disorder were first created. But what we're beginning to understand much better now is that in kids, we see something different. We see the little girl who has a vacant look in her eye. We see the little boy who's gotten kicked out of 3 preschools. And we see the adolescent who's increasingly getting into more and more trouble with juvenile justice system. So the question is, why? And part of it has to do with what the stressors are, and part of it has to do with the fact that these are kids. So we've talked a lot about the spectrum of stress that we see in childhood, and that some are positive and important for kids to grow and learn, that some are tolerable, but that many, many of our kids are being exposed to toxic stressors like abuse, neglect, parental substance use, domestic violence. And as Nadine started talking about before, when we experience stress, we have this activation of our hypothalamic pituitary adrenal axis, releasing epinephrine and cortisol, stimulating all those important parts of our body and immune system, and how very important that is to us to help us respond to stress and help us run away from the tiger or fight that tiger or hide. But the bottom line is that this hypothalamic pituitary adrenal axis was designed to last for about 20 minutes. Because in 20 minutes, you either fought off the tiger, ran away, or you got eaten. But in 20 minutes, it was over. But when the tiger lives in your home or your neighborhood or your life, something different is happening. And so what we have is this toxic stress pounding on the brain, saying, release, release, keep releasing the cortisol. And that cortisol is then having huge impacts, not just on the body systems responsible for helping you run at that very moment, but profound effects, as Nadine pointed out, on the immune system and on our gene expression, which all feed back to turn that system on and keep that system on. And so what we see then is all of that is happening in a child. Now, we all know through our pediatric training that the only reason a baby is born at 9 months is because you have to fit the head through a female pelvis. Because if you wait any longer, it's not going to make it. But when that baby is born, they are in no way, shape, or form ready to be out. They've got a brainstem, and that's it. Because the rest of the brain is really not ready to go. You have to have neuronogenesis, neuronal migration, arborization, synaptogenesis, and then a pruning away of what you don't need so that you can have maximal use of what you do need, and finally, myelination of the whole system. And so what we do is we give children the experiences upon which that neuronal system develops. So if I want a child to learn to walk, I have to practice that child again and again. Unfortunately, in my work with children who are abused and neglected, if a child is left in a car seat, they don't automatically learn to walk. They just can't. So we have to practice. For my own kids, if I want them to learn to play the piano piece, they have to practice again and again, despite their saying to me, Mom, I don't want to. And if they do practice again and again, they learn it. In fact, they don't even need the music after a while because the pathways are built. We have some fabulous research talking about language acquisition. We have to talk to kids so that they pick up language. We can't do it through the TV. We can't do it through any other means. We have to talk to them. And if that is true of positive experiences, it is also true of negative experiences. So for better or for worse, what's happening in the brains of kids is what's because of what their experiences have been. So it's our role then as pediatricians to start to recognize what we're seeing. By and large, those of us who practice pediatrics pretty much in our heads have this kind of a flow. For better, a little bit more, a little bit less, depending on the visit, but we get a history of present illness. We then move on to the physical and behavioral review systems, which no matter what the age of the kid's in, really boils down to, are you sleeping, are you eating, and are you pooping? And then the physical exam, the developmental behavioral educational screening that we do, and finally some anticipatory guidance. So for the purposes of determining if a child's been exposed to toxic stress, at this point in time, we really can't rely on the history of present illness all that much, because we're talking about things like domestic violence and child abuse and things that people have very good reasons not to tell us about. I hope that there will be some day in the future where families come in and say, Doc, you got to help me because my kid's got toxic stress. But we're not there yet. So we have to be able to pick it up with these other things. So let's start with looking at the behavioral and physical review systems. We'll take a case that is one that's really common to me in our foster care clinic. Foster mom comes in and she says that this 3-year-old has recently been returned to her care, which is not an uncommon story in foster care, that kids go home and then return to foster care. She is not sleeping. She's up till 1 or 2 in the morning. She wakes up early and no one in the house is sleeping, and so they're all really, they've had it. She's eating to excess. She tells them that she's always hungry. Even after she finishes a meal, she wants to eat more. They've tried to do some toilet training. It's not going well. And they've tried her in preschool, and she's already been kicked out. Well, before this conference, you might take it apart, and you might say, okay, from a sleep standpoint, are you giving her caffeine? Does she have electronics? Are you doing the bedtime routine? From an eating standpoint, are you setting up meal times? Are you letting her snack? And you might go through the regular toileting advice. You might also be tempted to go with the preschool ADHD diagnosis. Or you might have some more nuance and think, is this toddler depression? Is this developmental delay? Are there parenting issues? Because this child has obviously had some issues with parenting or she wouldn't have been in foster care multiple times. But let's look at it from a trauma lens. We know that corticotropin-releasing hormone itself has immediate effects on eating and sleeping. And what are those effects? Well, first of all, the reticular activating system is turned on and turned up. Because for heaven's sake, if a tiger is chasing you, don't go to sleep. And if you do go to sleep, wake up early. And while you're asleep, probably have some nightmares so that you wake up a lot. Also, if the tiger is chasing you, you have to keep eating because you have to have enough calories to keep running and keep fighting. So the satiety center is suppressed. And in fact, we see in kids that all the functions of sleep, eating, and toileting are significantly impacted by trauma, such that kids have difficulty with falling asleep, staying asleep, nightmares, the issues with eating. And with toileting, if you can't get to a relaxation place, you can't have normal toileting because the sympathetic tone is too high and you get constipation, then you get encopresis, enuresis, and toileting skills go back out the window. So how can you go back and do some screening? As Nadine pointed out, we don't have validated screening tools. There are things that people are using that are coming online. But even if I ask this family if they have ACEs, it's still not going to help me to know what symptoms this child has or how they're affected. So are there some questions you can ask? One is, since the last time I saw you or your child, has anything really scary or upsetting happened to you or anyone in the family? You can also take what you see and put it into practice and say, you've told me that your child's having difficulty with toileting, aggression, and sleep. Just as fever is an indication that the body is dealing with an infection, when these behavioral symptoms are present, they indicate that the brain and body are responding to stress or threat. Do you have any concerns that your child is being exposed to threat? So you get through that part of the exam. Are there any other places you can find evidence of toxic stress? Let's go with the physical. So I have a little video here, if my friends in AV will help me start that. And this might be something that you see.
So, John, your mom said that when you came in for your checkup today that you've been having a lot of headaches. Can you tell me more about when you're getting them and what they feel like?
Well, usually at school, sometimes at lunch and really loud, just like,
So you're getting them mostly when you're at school, not when you're at home?
yeah. A little, sometimes like before school, but
So is there something happening at school? Is there a bully at school?
no, it's just the kids in my class sometimes can be a little loud, and
Does the loudness make you nervous?
yeah, a little bit.
Do you feel nervous a lot?
I guess, but
Do you get stomach aches or does your heart race?
I get stomach aches too from that, and I usually in the lunchroom when it's too loud, I don't usually eat my lunch, and then there's my stomach aches that I get, and so.
And are you having trouble going to school?
Sometimes, but.
So John came in for asthma, and as Nadine pointed out, our risk of asthma is already high when kids have been exposed to toxic stress, so that may have primed you. But you may be thinking, this is a kid with anxiety, this is a kid who maybe's developed a school phobia, maybe he's just got poor management of this asthma and he's just always sick and that's why he doesn't want to go to school. But again, let's think about it from the toxic stress standpoint and looking again at that immune system and what happens in the bodies of kids who are exposed to early and prolonged stress. One of the things that we do know is that when the developing system is chronically pressed into action, there's actually a suppression of humoral immunity, increasing our risk of infection, while the inflammatory response persists long after it's not needed anymore. And the way I think about that is that if a tiger is chasing you, your body's really getting ready for a bite. It's not getting ready for the flu. So you have this turning up of the inflammatory processes, and really the humoral system is not that useful. But the other really fascinating piece that we now understand is that somatic perception is impaired, and so that you develop what's called a sick syndrome. And this sick syndrome, again, is hugely protective, right? Because if you have a tiger pacing in front of your cave, it's better off for you to stay back in the cave nursing your headache and your stomach ache. So that feeling of sickness under stress turns out to be a hugely protective thing. So you can take that and bring it back to the parent and say, the symptoms you describe and the trouble he's having with school and the feelings are often warning signs that the brain is trying to manage stress or threat. Sometimes kids respond this way if they're being harmed or if they're witnessing others they know about being harmed or they care about being harmed. Do you know of any violence exposure at school, with friends, or at home? And so you might not be shocked if mom does admit to you that there's domestic violence, and that you would know that John is having this increased inflammatory response and probably some sick syndrome going on as well. So what about moving on to our developmental, behavioral, and educational screening? Can we pick up anything here? And I do have another video of a friend named Dan, which might look familiar to some of you as something you might see in clinic. Can my AV guys start the video? Thanks.
So the nurse told me that in addition to just a regular checkup for Dan today, that you had some other concerns.
Yeah, he has been a little disruptive, having trouble focus, and I'm wondering whether he needs to be on some additional medication, or whether the medication he's on is right. You know.
Is what medicine?
Hold on. I'm talking to the doctor right now. I have to wait.
Is the medicine that he's been on, is that something he's been taking? Has he been getting it?
Well, he's supposed to take it in the morning and the evening, but the morning one he's at, Dan, sit down please. At the daycare, they're supposed to be giving it to him, but I'm not sure that he's getting it. Dan, come on back here. Sit down, please. This has really been very difficult. I mean, I've only had them a couple of weeks. Their mother is just unable to take care of them, and I'm working full-time, and the only time I see him is when I pick them up from daycare. Okay, hold on. It's just been really tough. I'm working all the time, and they're in daycare extended till 6 o'clock at night.
And how is his behavior at daycare and at school and with his sister? Is that something that's been a concern?
Well, at school, the teachers have talked to me because he has been in a few issues where he has not been paying attention. He's been disruptive. He's actually got in a little physical. Stop. Both of you, stop while I'm finishing, okay? And at home, he's been really picking on her quite a bit, destroying some of her property, her toys. He'll be annoyed by her and just fling her toys and break them, and just.
Is he hurting her?
Not physically hurting her, but just bullying her and teasing her, as well as just trashing her stuff.
And Dan, what do you think about this? Is that what's happening?
She's just so annoying. I can't stand it.
And how about at school? Are you having trouble focusing at school? You paying attention?
Sometimes.
How about your friends at school? Have you been able to get along with your friends?
Put that down. She's talking to you.
Sometimes.
So maybe someone has had something like that happen in clinic. No, nothing. But before this conference, you might have thought, is he not getting his medication? Is he under-medicated? Does he need a higher dose? After all, that's why she came in, because he needs something, or maybe he needs something different. Maybe it's moved on. Maybe we have to think about oppositional defiant disorder or conduct issues for him. Or alternatively, he's now in placement. Maybe he's got some depression issues. Maybe he doesn't function well because he's got some developmental delay. And clearly there's, again, parenting issues here. He's in the care of his aunt because something's going on with his mom. But maybe we should be thinking about it from trauma's perspective. And we know that there are particular parts of the brain that are affected. The amygdala, the hippocampus, and the medial and orbital prefrontal cortex are 3 of the most affected areas of the brain. The amygdala is an area of the brain that gets input from the sensory, memory, and attention centers, and you can think about it as the brain's emotional memory center. It's the brain's alarm system. The hippocampus is where there's the interface between the cortex and the lower brain areas. So it has a major role in memory and learning. It's your brain's file cabinet or search engine. Now, under stress, that amygdala is turned up, up, up. The alarm is turned high, high, higher. Meanwhile, the hippocampus actually atrophies because you don't want to be searching for a lot of information when you're under threat. I don't want to be thinking to myself, African tiger or Siberian tiger, what's coming at me? I just need to react. The frontal cortex is responsible for executive function, which is impulse control, working memory, and cognitive flexibility. And again, this comes offline when we're subjected to a lot of stress because we do not want to control our impulses, and we certainly don't want to be working on learning and developing other skills while we're trying to run away from the tiger. So the alarm turns up, the hippocampus shuts down, and the frontal cortex comes offline. And now that child goes to school or daycare. And so what does it look like? If we think about just the impact on the frontal cortex, working memory impairs the infant and toddler's ability to develop developmental milestones. They have frequent severe tantrums. They're aggressive with other kids. Attachment can be impacted. And they're easily frustrated. These are the kids that get kicked out of preschool. Once they get to school age, they're having difficulty with school skill acquisition. And if you don't have good working memory, you can't keep track of details. You can't remember what's going on very well. And also in your life, you may have people who say, tell me what happened. Tell me now. Or else there will be some bad consequences. So what's the most protective thing to do? Come up with an answer and come up with an answer quick. So these kids are called liars. They get in trouble with school because they're fighting and disrupting. And then they have organizational difficulties and they get brought to your office for ADHD medications and evaluations. As adolescence progresses, they have even more difficulty keeping up with material because of the impact on working memory. They have trouble with keeping everything organized, and that confabulation increasingly becomes looked at as an integrity issue. So now these are not just kids that lied, that are lying, these are bad kids. They have impulsive actions which can threaten their well-being and lead to increasing involvement with the law. And they have difficulty assuming the tasks of adolescence and young adulthood because they can't do two things at once. They can't take the order at McDonald's and make change at the same time. They can't drive the car and talk to their friend. They're not really good with that cognitive flexibility. But there's another picture that we should keep in our mind as well. And that one looks more like Jana, who came into his pediatrician's office because she used to be outgoing and bubbly and was then suddenly now withdrawn, depressed, anxious, and she had new school failure. We see a young child version of this, and we in our clinic call this the baby's fine syndrome, because judges tend to say, oh, I got problems with these bigger kids, but the baby's fine. Well, what the baby looks like is that they're really quiet and they never cry. We think about maybe they have developmental delay, but when I try to examine them, they stay put. They don't move, they don't fight with me. They're very serious looking. And both of these kids are ones that I might think about depression or I might think about developmental delay. But if I think about it from a trauma perspective, we know that the symptoms of trauma are related to the intensity and duration of adaptive style during threat. And for infants, young kids, females, those who cannot fight or flee, the best thing to do is to get as small as you can so the tiger walks by you. And so this is the defeat response. And it is involved with the dissociation, which describes the mental mechanisms of disengaging from the external world and attending to stimuli of your own world. So when we see that, it's sort of the opposite behavior, and we see this detachment, numbing, compliance, fantasy, and we can misinterpret what this is as depression, inattentive ADHD, or developmental delay. Jana's mom came back to that doctor 3 months later. She had been started on an antidepressant, but they weren't helping. She was cutting. She was saying she was ugly. And that pediatrician was an excellent one, and he knew that he should check for STIs in all adolescents. And despite the fact that she said she wasn't sexually active, he did. He checked her urine for GC and chlamydia, and her chlamydia was positive. And he went back to her and he said, you know, Jana, you told me that you weren't sexually active. And she said, you know, I'm not because I want to be, but my stepbrother's been raping me every time my parents leave the house. And that was our first clue. So now what do? How do we respond when trauma is identified in our office? What is the anticipatory guidance now? Well, the number one thing is to recognize for these kids and families that the trauma responses that they're having are adaptive and protective when the kids are in a threatening situation. Denise mentioned we have to change this mentality of what's wrong with you to what happened to you. Because we know that these body functions and behaviors may be maladaptive when we take the kid away from the stressor and we don't look at it in the context of the stressor. But if we can say to the kids, your bodies are doing exactly what they're supposed to do, those kids look at me in clinic and they say, you mean it's not my fault? And man, that is a powerfully wonderful feeling for you to be able to give that kid back that sense that they are not at fault. Kids are doing the best they can. And we just need to give them a little bit of guidance. So if we think about this family who came to us with the ADHD question, one of the things we can do is we can say, look, you know what? We respond based on what our experiences were. So I'll tell you, when I live in the center of Massachusetts, there's a lot of wooded areas. My kids and I go hiking, and if I come around the corner and I see one of these snakes, oh my God, I'm having a nervous breakdown. I'm telling the kids, help me, oh my God, it's a snake. I have a bunch of kids, they help me out, they get rid of the snake. We're all good. We live to see a new day. The kids and I decide, fine day, a couple weeks later, and I come around the corner and this is what I see. And I go, oh my God, it's a snake, it's a snake. And my kids look at me and they go, you're a Looney Tune. Because those are roots, Mom. And you know what? My amygdala was doing an awesome job of protecting me. It was reminding me of the threat that I had seen before and sending me right back into the state that was going to protect me. Because you know what? It worked the first time I got those kids alerted. They saved me from that vicious snake. So we have to help families understand that kids are responding to threats they have seen before, and that it may look pathologic to us if we don't see what they saw the last time. We also have to help teachers and daycare providers and these parents understand that kids come into their situation with a whole suitcase, an invisible suitcase full of how they perceive the world, that they are in danger, that they are worthless, and that they are powerless, and that you as a caregiver cannot protect me, that you are not reliable, and that ultimately you will be dangerous and rejecting. So that these providers have to become emotional containers for these kids in those settings, and not little Tupperwares, but I'm talking about big honking containers. Containers because these kids are going to have to give out their big, strong emotions, and these parents and adults are going to have to tolerate those strong emotions, recognizing that they may act out with those adults, but those emotions are not about the adults that they are with at that time. And that if they can respond calmly and help those children to name the feelings, that we're going to do much better. Because if they respond with that same strong emotion, they're going to send that hypothalamic pituitary adrenal axis right off again, and we're not going to get anywhere. And in fact, we're going to continue to further traumatize that child. There are some resources that you can keep on hand, and the rest of this conference is going to be sort of spent more on how to do this in the office and how to kind of come up with these resources. But keeping parenting supports, knowing what you've got in terms of parenting programs in your community, early intervention, quality childcare, school resources, grandparents raising grandchildren resources. A bunch of the speakers have talked about how important it is to exercise. When we are under threat, we need to move. For those of us who lived in Worcester last winter, every snowstorm started off wonderfully. We all lit the fire, we turned on the movies, and in 2 hours, we were out of that house, shoveling, throwing snow at each other, building snowmen, because we had to move. Under threat, we have got to move. Also, this mindfulness training, prayer groups, yoga classes, helping kids to learn the skills about how to bring themselves back, how to manage these strong emotions, are so important to the kids. There's these resources which are in the resources that we have put together for you. Also recognizing that there are specific therapies for kids who have been exposed to trauma. Just as none of you would tell a family, you know, I want you to go see a specialist, and not make it clear to them whether you wanted them to see the cardiologist or the neurosurgeon, we don't want to refer families to therapy, the wide-ranging therapy. For kids who've been exposed to trauma, there are evidence-based trauma therapies. And these are not the only ones, but these are some of the ones that are best supported by evidence. For young kids, there's child-parent psychotherapy, and there's a therapy called parent-child interaction therapy, which is much more of an attunement therapy, but all of these help the parent of a young child help move that child past what they've been through. For kids who are a little older, trauma-focused cognitive behavioral therapy is there. And for kids who've had complex trauma, where they've been exposed to multiple types of trauma, like abuse, neglect, domestic violence, things like attachment, self-regulation, and competency, or the integrative treatment of complex trauma. Those are things that we need to be able to move these kids into. There are a number of resources now on AAP's website. The National Child Traumatic Stress Network is a place that you should become very familiar with online, and the Center for the Developing Child at Harvard University also has some fabulous resources. So things that you might want to do: recognize how trauma may present, consider trauma symptoms throughout the medical visit, keep it in your differential diagnosis, even if you think it looks like something else you commonly see, have a strategy to address the various symptoms of trauma, create a resource list for the practice to easily access, and resources at your fingertips to provide to families. So why is it important that there's snow in Worcester and I have a lot of kids? Because all those patients bear a remarkable resemblance to me. Because those were my kids doing a little acting for you. Thank you, everybody.